this is not an immediate thing you would think of for uveal melanoma, and I'll try and explain why we might consider it. But it's come out of a trial that we've been doing in melanoma that originally was conceived in 2010. So before all that raft of treatments Damien's just told you about that have been very effective for melanoma. So I'm certainly not putting this up as a treatment for metastatic cutaneous melanoma. Number of disclosures. This is being done in collaboration with Baylor College of Medicine in Houston. And the target of these, so CAR T cells, chimeric antigen receptor T cells, I'll show the structure of one in a minute. They're actually approved now in Australia for B-cell malignancies, where they have high initial response rates and maintain remissions in over half of patients with relapsed refractory disease. So a lot of interest in this technology. And the target here is GD2, which is a glycolipid antigen. It's expressed highly by cells of neuroectodermal origin. These include neuroblastoma and more recently diffuse intrinsic pontine glioma, very highly expressed at childhood brain tumour. A lot of the biology in the literature goes back 20, 30 years, and I'll come to that in a minute. Has restricted tissue expression on CNS neurons and peripheral nerves in melanocytes. And this particular one is a so-called third-generation CAR. It incorporates a suicide gene. That's a schematic of the retroviral vector construct. But essentially what happens is that it sits up as an antibody fragment that can bind to the antigen here, GD2 of interest, on the tumour cell, and a bit like the Immunocore technology, then link it indirectly to the T cell. So it links the T cell, the Immunocore technology, via CD3. This goes directly via the membrane to a set of signalling domains inside the cell that provide the signals in the cell for their recognition, activation, expansion in vivo ideally. And the suicide gene, I won't go into in any detail in the interest of time, but a small molecule drug can be administered if necessary, and it has a way of switching on the death of the cell if required. So in our trial we had planned to enrol 16 patients in total, but we've changed protocol and explain that in a minute. But most of the patients, 5 out of 6 we enrolled first, were V600 BRAF mutant disease. And the design of the trial was to give them the T cells after they had blood taken to make them, just before they commenced the BRAF first and then combination BRAF-MEK inhibitor therapy when that became available. And the rationale for that seemed a very good one at the time and actually drives some trials since. So if you have BRAF mutant disease, you give an inhibitor, you increase the expression of some antigens, melanocyte differentiation antigens, for example, that are recognised by T cells when presented on the surface of the melanoma cell or cross-presented via antigen-presenting cells. If you get cell death induced by the BRAF or MEK inhibitor. And then you have release of immunosuppressive factors. They include vascular endothelial growth factor or VEGF. They're suppressed by BRAF inhibitors. And you have increased attraction into the tumour post-treatment of T cells. So we thought, well, this could be magic. And this would draw T cells in, including CAR T cells. So we did modify the protocol to let patients in who had BRAF mutation negative melanoma, in which case they would then get a cycle of lymphodepleting chemotherapy to make room, create homeostatic cytokines that would enhance proliferation of the adoptively transferred CAR T cells. Primary objectives are not surprising: feasibility and safety of CAR T cell manufacture and products. And the secondary objectives, mainly looking at the persistence. Tumour responses are really not so relevant here because all of these patients, bar one, are on active treatment, and we haven't yet looked at bystander immunity. And then patients have been, as I said, had their blood taken at screening. they need to have at least 10% or more of tumour cells expressing GD2. If they have an eligible BRAF mutation, they get PBS supplied dabrafenib and trametinib, and then the CAR T cell infusion, and then in a 6-week dose-limiting toxicity window are followed up, and then we're required to follow them up annually because they've had retroviral gene transfer. And that's a schema of the patients who've been enrolled. I do not intend to go through this in detail, except to say 5 of them were BRAF mutant, had concurrent treatment. 1 had lymphodepleting chemotherapy. 5 out of 6 are alive, various stages of disease progression, but some are in remission. So this one's been on multiple therapies. So this is now with modern anti-melanoma therapy, many other treatments people can get access to. The patient who had the lymphodepleting chemotherapy subsequently went into complete remission with ipilimumab. I won't go into any more detail, but really what I wanted to point out is that the CAR T cells we adoptively transferred had, in a couple of cases, a brief period of expansion, really no persistence beyond a couple of months, with the exception of the individual who got the prior lymphodepleting chemotherapy, where they expanded to a much greater degree and persisted for 8 months, and this was around about the time the patient had ipilimumab, so they didn't actually become detectable after that. This is using 2 methods, so quantitative DNA PCR assay for the CAR transgene and the T cells from blood, and this is a flow-based method, flow cytometry-based method based on an antibody that recognises the CAR. Now, there are a bunch of different causes for why this might happen. We've published on this recently to work our way through these. We think the fact that this patient got lymphodepleting chemotherapy prior to treatment was significant. The Baylor group we collaborate with have done a similar study in neuroblastoma and did find increased expansion and persistence with prior lymphodepleting chemotherapy. We don't find any evidence because it contains mouse-derived domains that the CAR has been deleted by the host immune system. There is some role for PD-L1 expression, and perhaps in vitro at least we could reverse some of the problem with the T cell by treatment with pembrolizumab in vitro. But what we did find is that these CAR T cells were overactivated and dying prematurely, and without going into detail, we have now modified the ex vivo culture condition to favour the production of these yellow and orange stem memory or central memory phenotype cells, which is really condition 3, where we'll go into a modified protocol versus condition 1, which is our standard protocol we've used for these 6 patients. Where you see here the blue ones are really the more terminally differentiated effector cells versus a much reduced fraction of those using this new cell production method. So what we plan to do, we have this with TGA in a variation to our clinical trial exemption, new protocol submission to our ethics committee at the moment to broaden eligibility to other GD2 positive malignancies. I've named a bunch of them there. There are a bunch of soft tissue sarcomas, osteosarcoma, small cell lung cancer, triple negative breast cancer, a fraction that express GD2, and I wonder about uveal melanoma. I've already explained about the alteration, and in the first cohorts at least we won't use lymphodepletion, given we've modified the manufacturing method, but I think if we don't get expansion we will go back to TGA to ask to use this, which we have in the former protocol. Now, the evidence for GD2 expression in uveal melanoma. All of the literature is more than 20 years old. I didn't do a systematic literature review, but at least a PubMed search. This is what I could find. Varying results, so contradictory results. Very convincing seeming lack of reactivity using an antibody apparently identified both GD2 and GD3 gangliosides in one study from 1989. Another study used a different method of high-performance thin layer chromatography to identify the actual gangliosides, 14 primary uveal melanomas, 19 cutaneous melanomas, and they did find expression of the GD2 in the cutaneous melanomas where it's known to be expressed. This is percentage of the fractions that yielded GD2 for those, 0.5 to 22%. But in the primary melanoma cases, GD2 was near the limit of their detection or not detected. In another study, they looked at 20 primary uveal melanomas, 2 derived cell lines, a hepatic metastasis uveal melanoma, as well as 8 normal choroids using the same detection technology, and didn't find any expression in any of those tissues, and this is here cultured in vitro. But when they xenografted as subcutaneous tumours these 2 lines, there was expression of GD2. So there's something about being in an altered host environment that induced expression of GD2. Now, it is known that GD2 expression is highly dynamic, very sensitive to cell contact overgrowth. And in a follow-up study, this same group had taken one of those lines and then they subcultured to get heterotropic metastatic lines of varying metastatogenicity. So when they looked at GD2 expression, the ones that were less metastogenic, they found lower GD2 expression. Higher metastatogenicity, they found lower GD2 expression. And then finally, there's another trial or a study rather, that used the same antibody. So none of the studies before have used the antibody we actually have in the CAR, but this particular one did use that. Looked at only 3 uveal melanoma cell lines, said they expressed GD2 by 2 methods, indirect immunofluorescence and flow cytometry, and then they inserted the tumours into the anterior chamber of the eye in mice, and they were able, interestingly, they did several kinds of experiments, but this particular one with intracameral tumour, inoculation, subsequent enucleation, and then looking for development of liver metastases, were able to show they could almost completely block development of liver mets using the same antibody that contributes to the CAR for the CAR T cells that we have, and interestingly is also the antibody that is used as consolidation therapy post-chemotherapy neuroblastoma, a GD2 expressing malignancy. So again, all of these are very old data. So that's the end of my talk. So I guess I'm making a plea for anyone who has metastases, if they might get in touch with me. We can look for GD2 expression. When we get the trial going, and Anthony's already asked me when he had one patient to see if they could go on to this, we can screen their tumour tissue, obviously, for GD2 expression. We've got a low level of expression required. It's primarily a safety study. Thank you.
Any questions? We just published Princess Margaret Experience and Adopted T-cell therapy with low-dose subcutaneous IL-2, which may help with the persistence of the T-cells. IL-2 is a bit of a dog's breakfast in Australia, but did you think about giving a smidgen of IL-2?
No.
Okay.